All right. So, hello, welcome to our session titled Introduction to Neonatology. Our guest speaker today is Dr. Safdar Khan. He is a neonatologist currently serving at the Nationwide Children's Hospital as an attending neonatologist. He completed his medical degree from Rawalpindi Medical College and completed pediatric residency at John H. Stroger Hospital of Cook County and his Neonatology Fellowship at University of Kentucky. Welcome, Dr. Khan. How are you doing today?
Very well. Thank you, Zanem. I really appreciate you for this opportunity to talk to you guys. I don't know how you have done these sessions before, but I like more informal kind of sessions
Mhm.
where you can interrupt me anytime. Please don't mind. Just stop me anytime. If you have a question, I'll be happy to answer, and
All
then
right.
we can move on. Okay.
Perfect. Thank you so much for taking out time from your schedule. So, our first question is, how has your journey in medicine been so far for you?
Yeah, so before I go and delve into this question, I would like to tell you my background.
Sure.
Um, I was born in a village. It's like I would say around like 30, 50 miles range from Lahore up north. If you ever been to Punjab, if you drive from Lahore to Sialkot,
Mhm.
so there's a town, Wando, that's the name. That's where I was born and raised. I did my metric, from the high school there. I did FSC from Lahore. There's a famous college, FC College or Foreman Christian College. It was established like 1864. That's pretty old college. That's where I did my FSC. And then I did medical school, as you mentioned, from Rawalpindi Medical College. I graduated in 2005, did like 1 year house job at Services Institute, Lahore. Then I did like a couple of months of uh, in pediatric oncology at Shaukat Khanum Hospital. And I think that was kind of life-changing time for me because I made a big decision which I was thinking differently before. And I can elaborate more that I changed my specialty basically when I worked in Shaukat Khanum.
Okay.
Before that, I was not very interested, or I would say I wasn't very exposed to pediatrics.
Right.
And I'm more kind of an internal medicine person who was
Mhm.
thinking internal medicine or surgery. I
Mhm.
even did like FCPS part one in surgery.
Oh, okay.
Yeah, but I changed my mind when I did like 2 months in Shaukat Khanum in pediatric oncology.
Mhm.
Yeah, and then I'm not sure if you want me to stop or you have more questions. I can keep going.
No, you can go ahead and give a general introduction about yourself, and then we'll go ahead with the questions.
Sure. Yeah, and then um, at my time at Shaukat Khanum, I kind of felt that I'm happier when I deal with pediatric patients. I feel more like empathetic. I feel like this is something I should like, that should be my primary specialty. And that's how I applied for residency to peds. And actually, I got only one interview
Oh, okay.
in pediatrics, and luckily I got that. And the interview went really well at Cook County Hospital, and I kind of knew after the interview that they will rank me really high.
Mhm. Uh,
And then,
sorry,
af-
let me just participants. Oh, sorry. You can unmute yourself, Dr. Khan. Sorry. Yeah, go ahead.
oh, sorry, did I go mute?
Yeah, I accidentally did that. Go.
Oh, okay, okay, got it. Yeah, um, so my time at Cook County as a resident, actually, I had made my mind in the very beginning that I want to do neonatology, and I can answer those questions because why I chose neonatology as a profession.
Mhm.
Did like 3 year of fellowship at University of Kentucky, as you mentioned, and then I was worked with the University of Miami for 7 years as faculty.
Right.
I had an academic job, and my current job is actually more like a private practice model. So
Okay.
I have seen both sides of it now, like how the private practice works and how the academic, uh, uh, you know, uh, an academic position, you have to, what kind of things you need to do. So that's kind of my story, and I will let you guys ask me any questions.
All right. Perfect. Thank you so much for that. So we just have a bunch of questions that we've developed for you. We'll
Okay.
go through them one by one. And then if the audience has any questions, please refrain until the end. And then we'll go ahead and open question and answer for the audience. All right. So Dr. Khan, how has your journey in medicine been so far?
I think, to be honest with you, uh, in Pakistan, most of the kids, they don't choose medical profession from their own will. It's the peer pressure, the pressure from the family, all those things. But I feel like in one way it's good, because I was in that kind of problem too, because medicine was not my primary choice. I wanted to be engineer, and I have a fascinating story to tell you,
Go
like
ahead.
how I came into medicine. I um, in my family, we have a like a I have a lot of siblings. They tried for medical school. Um, my mom wanted one of her kids to be a doctor. She always had a desire. So she tried, like, my siblings, they tried. And so unfortunately, they were very close, but not enough.
Mm.
And then I tried, I failed actually the first year. I even thought, okay, so it's done and dusted. I'm going to move on. And I actually took admission in BSc medicine, in FC college.
Mhm.
And then one day my mom went to Sheikh Zayed Hospital, you probably heard about,
Yes.
and she actually came back. She was talking to someone else, I wish, she mentioned my name. I wish he was a doctor. And then I really felt it.
Mhm.
I felt really deeply. I felt like I should try one more time. So I actually did repeat everything again. I did not tell anyone, not even my family. So I did like the whole FSC, first year, second year, the entry test, everything. I went through all this process. And once I had my admission, I told my mom
Wow.
that I'm going into medical
You
school.
must have been so happy.
She was very happy. And, the life is full of tragedies. So the same day I told her, my
Mhm.
mom's sister died. She was sick.
Okay.
So it kind of was a little bit of low profile celebration, but
Mhm.
she was very happy for me. But then I started liking medicine. So you see, you can make a decision under pressure, but I think you probably may like it. Like now, I enjoy medical profession, and I feel like it's a blessing to be a doctor. It's losing a little bit of that kind of prestige it used to have, but I think it's still, we should feel that we are in a very noble profession in many ways.
Right.
Um, so you can think far and beyond, and there's so many arguments you can make, but still it's one of the best professions. So I personally, going back to your question, I really still like working as a clinician, talking to families, uh, and I can answer more of these questions if you have, but there are a lot of things I can talk about it.
All right. Perfect. Thank you for that. So you answered our next question about how you chose medicine. So we will move on. What made you choose pediatrics? I know you talked about pediatric oncology, Shaukat Khanum Hospital. So can you delve into that a little more?
Yes. So um, my experience before I did 2 months of pediatric oncology was that I was thinking I should do either surgery or internal medicine. That is what I was thinking.
Mhm.
But one thing I realized, and I am a kind of person who think a lot objectively, like, what is my end goal? I felt like the end goal for everyone is to be happy.
Mhm.
And when I studied all the subspecialties, and I noticed that the pediatricians are actually the happier people.
Mhm.
they may not have enough money, they may have less money than any other specialty, but they're usually happier. So I felt like at the end of day, it doesn't matter how much I earn, how much I am respected, but if I'm not happy, the chances are that I will be suffering,
Mm.
like with all the hard work. So that's why the pediatrics appealed to me more. I feel like, you know, that was the my background study part. Then when I practically saw, when I uh, talked to the families and the parents, when you work in pediatric ward, you have to be gentle because you're dealing with the kids. You have to be nice, you have to be empathetic, you have to be soft spoken and all those things. And then I felt like you have to create those characteristics in yourself,
Mhm.
and they automatically become your second nature because you are always acting the way you're supposed to act uh, in pediatric ward. So I think that I felt, because I had a strong comparison when I used to go, like, uh, the other specialities, and there was a sea change difference. The people who, like, not just the nursing staff, like, the other people, even your seniors, they will treat you nicely. I
Mhm.
think this was, going back to the basic question, what drove me towards pediatrics was this was one of the reasons, I would say. Yeah, so as a general peds, that's how I actually I chose. And after 2 months, really, I felt like, okay, this is it. Okay, I'm not doing anything else. And you can imagine that oncology is not a kind of rewarding specialty in many ways, because of you see a lot of suffering to the families because of their kids getting diagnosed with like hematological malignancies and whatnot. But still, I feel like, probably this is way, um, like it creates some kind of purpose in your mind. That is why I felt more comfortable doing what I was doing.
Right. Thank you for that, Dr. Khan. So the next question we have is why neonatology?
Yeah, so this is a very interesting question. So when I was choosing subspecialty, one thing I noticed that, I have spent so much time to learn a lot of things: ophthalmology, ENT, and surgical things, and all these things. I have learned so many things, and now I'm just going to practice one focused area. So that was kind of not very exciting for me. I felt like neonatology actually gives me like an option where I actually interact with everyone. So the main thing which appealed to me about neonatology is that I interact with almost every subspecialty you can think of. Like,
Mhm.
I talk to ophthalmologists because we deal with the retinopathy of prematurity. We need to interact with them. I talk to ENT guys. The baby can come with stridor. I talk to pulmonology because they can have BPD or bronchopulmonary dysplasia or chronic lung disease or asthma, right? So similarly, GI specialists is the main, like, the feeding, similarly surgeons, like, I talk to surgeons because there could be a surgical case in neonatology. I need to interact with them. More importantly, I need to talk to social work, psychiatrist, the family. So you see, it has so many dimensions. So I think neonatology is a very unique specialty. And I'll tell you another thing which you will see as very unique aspect of neonatology is you will not see many specialties where people go into the hospital for celebration. you
Mhm.
know when a baby is born, they go,
Right.
that's the only. And if you see, so when you work in a stressful environment in a hospital, this aspect of festivity, happening, it actually offsets some of the negatives we get.
Right.
So those things, when I thought through, kind of, I felt, okay, this is actually a great subspecialty. The other thing aspects is, if I some people like inpatient, right? They like more to work in the hospital setting. Other people will like to work in outpatients. It also gives me both opportunities. It
Oh,
also gives me opportunities to do procedures. I can do like a central line placement, like umbilical lines, intubations,
mhm.
some of the minor procedures you can do, like circumcision. You wouldn't believe how many circumcisions I have done so far. Yeah,
Oh,
so these kind of things you get, like, procedural aspects which are taken care of, and then the physician aspects, the clinician aspects are there, and then collaborative aspects. You have to collaborate with so many special subspecialties. So I think in that way, neonatology is a unique subspecialty, and many people would argue that there should be a separate primary specialty as a neonatology, separate than general pediatrics, because it encompasses everything in itself. So those are kind of the driving factors which actually brought me to the specialty. I thought about others too, but I think this was the main reason which I just explained to you.
all right. So, did you have other fellowship options in your mind, or was it always neonatology?
I was very open mind when I started my residency. And I will be honest with you, the first rotation I did in NICU, the neonatal ICU, I did not like it. I saw like so tiny babies. I don't know how we handle these things. But
Mhm.
then every next rotation, I liked it more. And when I did the fourth one, I made my mind. Actually, I said, this is great. I think one of the reason was because I wasn't very I wasn't exposed to the NICU setting a lot in Pakistan when I was in medical school, and even when I was doing my house job. So I think the main factor was the more you are exposed, the more you know this specialty, then you start liking it more.
Mhm.
Um, yeah, I didn't think about much after I made my mind, and I think I made my mind by the end of second year already when we apply for fellowship. Like, yeah, when I was applying, I already went through that brainstorming that what I'm gonna do. But I went through it. I did, but as I mentioned, like all those factors I just mentioned, they actually drove me very clearly towards neonatology.
All right. So, while we're on this topic of fellowship, we've talked to a few pediatricians and they've discussed how pay is an issue with peds in general and also with the fellowships that sometimes pediatricians do fellowships, but they end up having the same basically like monetary benefit as someone who doesn't do a fellowship. So what is your stance on that?
I think, unfortunately, pediatricians are victims of their own success. Because you know, the way financial world works. The numbers matter.
Mhm.
Like, how many patients you see, how many procedures you do, with the vaccinations and all the wonderful work the pediatricians has done over the years and decades, in the last few decades especially.
Mhm.
The vaccinations especially,
Yeah.
and also the Western world where we practice is different in terms of pediatrics as a subspecialty than in Pakistan. Pakistan, it's still pretty busy because we have a young population and the birth rate is pretty high.
Mhm.
In US and Western world, the birth rate is low, plus the vaccinations are usually very helpful to prevent babies getting sick. So
Mhm.
those numbers translate into the financially not like very income generating subspecialty or specialty.
Mhm.
um, so I think, um, as I said, I will go back to the initial point I raised, that at the end of the day, you have to see what makes you happy. It, I mean, we relatively earn less than other subspecialties or specialties, but we still earn decent enough that we can live happily. That money, yeah, and I'll tell you a very interesting point here, because I don't remember the name of the study, but there was a study where they compared like how much you earn and how happy you are. Okay. So there was a direct correlationship between, if you earn more, you will be happier. For example, if you earn 10K US dollars,
Mhm.
versus 20K, you will be happier with 20. You will be happier with 30
Right.
until you hit a plateau, which usually is 70 to 80 or 90. Maybe with inflation, it could be 100 or
Mhm.
120. But pediatricians, they can easily earn near 200 or above.
Right.
With a little bit of extra effort, they can easily go to 300. With a subspecialty, they can easily cross 250 um, with a little bit more effort. The other aspect you have to consider is like whether you want to do an academic job or a private practice, because academic jobs are more kind of prestige jobs, and you have a designation as an assistant professor, associate, or professor. You will be publishing, you will be getting funded, you will have a track where you will move up on the ladder in academic setting, which will uh, the the trade-off is that you will have to compromise on the salary. Like you will be paid less. Private practices, they kind of, I would say, and I'm going to throw numbers in general, and these are not like, this is just a rough estimate. For example, if you are a general pediatrician, you might be earning in academic setting probably near 200 or even less in a lot of places. I think way less than that, some places. But if you're a private practitioner, you might be earning 300, 350. So, but as I said, like, at the end of the day, the happiness is driven by the money factor, but it's not the only thing.
Right.
The more money you earn, you're putting more efforts and time away from your family, friends. So you're missing something. It's not that, so you sacrificing something to get all those things. So I think those factors, everybody thinks differently. Some people are way driven by the financial aspects, which is fine. We don't want the world to be same. We want everybody, and that's the beauty of the world. Like everybody should not be the same. Everybody should have some difference. Some people think more academia, which is fine because some people need to do academia. Otherwise, how we will grow. And
Mhm.
some people need to think more financial aspects so that there's more economic activity and more growth. So everybody should choose what they want. Um, so my say on that is that um, it's too early for you guys, for example, as a final year medical students, or third year, fourth year, to think that deeper into it because you're not exposed enough to the training, um, because you want to make a decision which is best for you in
Mhm.
your circumstances, your motivation, your long-term goals and aims.
Mhm.
That varies a lot between person to person. So that's my take on it.
All right, thank you for that. So you touched up upon private practice versus public or academic. So what do you think is the reason that private practice earns or gives more money than academic? What is the cause of that?
Well, it depends on the financial model. Most of the academic jobs, you are basically doing like teaching, research, those kind of things. Like you're supposed to do, like you're supposed to publish, you're supposed to get funded from, ideally from NIH. Uh, so you are not doing clinical work.
Okay.
So like you're doing clinical work, but way less than a private practice. For example, I worked in academic job where I will work like 6 months clinical and 6 months I will either do research. So research is kind of more like a service to the humanity, basically. You
Mhm.
are publishing for the future generations. You're publishing, you're getting funded. So it's not like income driven kind of area. On the other hand, if I'm doing the whole year private practice, I am generating money. The patient is coming to the clinic, to the NICU, or to the hospital. Insurance is paying for that service. So you are generating income. So that is why, because these private practices, they look at the the salary they pay all the employees plus how much they earn.
Right.
So a lot of times you are earning overall as a group more than um, more than what your target is, and then you also get extra bonuses, whatever revenue you're generating, you may have even shares in it.
Mhm.
And I think there are different aspects to it, but um, going back to your question, why academic jobs they earn less money than private practice, is because academic job is mainly a service to humanity.
Mhm.
And people who are driven in academic job, they usually are driven by um, you know altruistic mind. They will be thinking of, okay, I want to publish so that next generation of physicians can build on it. That is one factor. The other factor drives them is the prestige. Okay, I'm going to become assistant professor, associate professor, professor. Some people will be driven by the educational motivation about it. But private practice is most of the time, and that most of the times, not always, is driven by the financial model, because your purpose is to earn money.
Mhm.
A lot of private practices, they are not for profit, they are for profit. So they're basically, you're working as in Pakistan, you have a clinic and you earn money from the clinic. You charge people when they come. If you have insurance, you charge insurance company, like in US. So that's the reason there is a pay difference.
Okay. And then just last question about this private versus academic. So we are familiar with some doctors that have a private clinic but are also part of a university hospital. So would that be considered as a private practice or a university branch? Like,
So sometimes there is not a clear demarcation line.
mhm,
There are a lot of hybrid programs too. Like, for example, I will give you an example. I worked with the University of Miami as a faculty. I was assistant professor with the University of Miami, which is a private university. Okay, but it's an academic private university. Yeah, that was my role. But we were practicing in a hospital, which was a county hospital, which was kind of public hospital.
mhm,
So a lot of places, they have some kind of contract with an academic institution,
mhm,
because the students come there. For example, I might I'm doing private practice right now, and I might get, like um, an offer. Okay, you can be assistant professor, as well, if you can help with our medical students, if you can help with our fellows and residents. So those options are there. uh,
right.
but when we talk about private and academic, that is a full-time and academic job versus a private practice, which has no link with the university or an academic setting. But there are a lot of hybrid models.
Okay,
Yeah.
perfect. Thank you so
Yeah.
much for that. So can you share anything about the match process for you? How was that journey like?
Um, so it's it's kind of long process, one thing. Um, it requires a lot of motivation, determination, and consistency, perseverance, these kind of attributes to be successful. You um, you have to, first of all, when we did USMLE exams, so there were, like, step one, two, step two, CS, CK, and then step three. So all these exams, basically, you are studying everything again. Basically, you're going through again. I noticed that now step one is just pass and fail. I think, and it used to be like, we used to score high in step one and then step two. So that is one aspect of it, that you have to score well,
Mhm.
right? The second aspect is the financial aspect. You have to create resources to back up those exam fees and expenses.
Mhm.
And the third aspect, you need to have motivation to sit another at least 6+ months for those exams.
Mhm.
And the fourth aspect is that you may do all these things perfectly fine, but you may still get a hurdle in visa. Okay, so that's another barrier. Okay, if you don't need visa, then I think this is much easier process if you need visa. And then after you get visa, then you apply for residencies in different hospitals. You have to find hospitals which are IMG friendly. That is the key for a person who is graduating out of the US, even Caribbean. They have to find programs which actually take. And the simplest way to know which programs you should apply, just look at their roster, look at their fellows and see if they put in their medical school names. And then you will see. I think it's a waste of money from my experience that if you see in the last year they have not taken more than one or two IMGs, it will be very challenging. And those IMGs usually they have some connections in terms of their spouse might be there, or they might be living there, or they might have done some research or something there. So you have to be very realistic because it's a very expensive process once you apply for all those programs. Uh, but as I said, like, if you are consistent on your goals, you keep trying, ultimately, and my belief is that you get those things. It's just like people stop it prematurely. They just, so people say either you lose or you learn. So you keep learning how to improve yourself and try again. That is one, if you're very strongly determined to do something. But at the same time, you have to also be mindful of the cost analysis of it because it can be very expensive endeavor.
Mhm.
Yeah.
All right. Thank you for that. So, how was your personal process like? How was your journey like towards matching? Did you find that the process was easy or difficult? Were there specific hurdles that you were not, you didn't think would happen, but how was your process like, basically?
I think the main thing is that you have to plan ahead of time. As I said, like I had only one pediatric interview.
Mm.
Um, I think main reason was I didn't have step three in my hand. I
Okay.
think some programs which I applied, they were heavily focused on step three scores as well. And the other thing was that I needed a visa, obviously, and that actually filters out a lot of programs. Um, so for me, I think it was tough. I at one point, I had made my mind like what backup things I'm gonna do if I don't get, you know, any position or if I'm not matched. So I had already streamlined. I will do step three next year. I will do this thing. I will do some publications. I think with the changing world, the number of candidates any program gets is like thousands for like small number of positions. So you have to compete like very highly qualified medical students. To counter that, first you can score high in step two.
Mhm.
One thing. Second thing you can do is you can I think if it's specifically about me, I think that's what I was thinking, that my scores were good and CK, which made a difference, I think, in the end.
Mhm.
Step one score was also good. And then I interview skills matter. Okay, and I will tell you very interesting. I think I told you that when I interviewed, I kind of knew that they're gonna rank me high and it probably will be matched.
No, you didn't mention.
And yeah, so the reason was that because small talks, they matter a lot. You know, if you go to a residency program, I think they know that they have so many high scoring individuals and they have so many well qualified candidates. Which one we should choose? So if you ask me, the most important person they're looking is the one when they work with is actually easy to work with.
Right.
get along well with people. Okay. And if that person comes and joins our team, will work hard, will not complain too much, will be easy to talk to, and to actually polish that skill is very important. Like how you do small talk, how you do conversation with people when you meet.
Mm-hmm.
Do you know how to, like, ask, like, make people interested, like, in your conversation? So those all are personality skills.
Mm-hmm.
You see, the interview is not really on the knowledge, because you already proved it. And it's also not on your experience and background and whatever you have, because they can see it.
Mm-hmm.
It's about you as a person. Like, is it easy to talk to you? Are you gonna just make our life miserable when you're here?
Mm-hmm.
These are very important aspects of an interview. And I think the luck also matters, because the person who was interviewing me, he I mean, he asked me questions which kind of excited me, so I got delved into them. So, but if you practice, you can actually increase those skills. They, at the end of the day, they want to have a person who is lively, who is motivated, enthusiastic, knows common routine normal life things, like how to live life out of the hospital, the common basic stuff.
Mm-hmm.
Those things we should polish. I think that's where we lack as IMGs, because we're coming into different culture. We
Mm-hmm.
don't know the language a lot of time, because that translates into patient care as well. That's why they also want to focus, because if you're going to interview a family, and they don't understand you, the body language matters too. Like, you need to know how the body language works in Western society. It's actually not the spoken word, but how your body gestures are. They all matter in the end.
Right. Okay. Thank you for that. So, you mentioned to us in your biography that you have a master's in translational health. So, can you introduce this to us? What is translational health?
Translational research,
Sorry,
yes.
translational research.
Yeah. So, when you do fellowship, you have to do a research project. And many programs, they offer you, like, you can also do a master's degree as well, because that also will fulfill a requirement for your fellowship training.
Mhm.
So University of Kentucky, they were just, I was actually one of the first one who did masters in translational research in our batch at that time,
Mhm.
because they just had started. So what translational research is basically, from bench to bedside, basically, like, so there is a basic science research and there is a clinical research, right? What is basic science? You do in the lab. You're doing whatever you're doing in the lab. So you're doing on animal models, or whatever you're doing. That's called basic science research. And then you have a clinical research. You do randomized controlled trial, like, want to see this a drug A works better than drug B. So
Mhm.
that's clinical research. And then there's a research which bridge that gap,
Okay.
because randomized controlled trial, like research, is the end product of a streamline started from basic science, which has like a pilot studies as a translational research. So that is what translational research is. So the idea was, I think this was started, probably 10 years ago. Um, there was more emphasis on that we are doing a lot of things in basic science, but we are not translating into clinical effectiveness or clinical applications of it.
Mhm.
So that's why they came up with the idea that, we should have something we call translational research. So basically, my training was like how to conduct a research, how to design a research, ethically sound research, and how to run a trial, how to do meta analysis, how to do like statistical analysis of the research. All these small things are included in that curriculum. So, and that was also part of our training as a fellow. So that's why I was lucky enough that I actually, I presented, my program director actually requested me to present this translational research masters to one of the AEP meetings.
Oh,
And I presented that because they presented me as like, this is the one of the graduates we have.
okay.
So yeah, so I think it's we if you are in academia, as I said, I did work in academic settings, so this helped me a lot. It also teaches you how to get funded, because remember that to write a grant writing is a big thing. Like if you know how to write a good, like a grant, and you are in academic setting, that is something they will value a lot.
Mhm.
Yeah. So
Okay.
yeah, so translation research, I gave you like a quick snapshot.
Okay. So, just to repeat, it was basically a requirement for your fellowship, but it did give you a lot of tools to write grant research, write the, sorry, what did you say? Grant funding?
uh, Grant writing,
Grant writing.
like, yeah, if,
Okay.
a lot of research which we do in United States, it's usually uh, it's usually funded at some level by an institution,
Mhm.
like especially if you are doing an expensive research. For example, who's going to pay, and you apply to the National Institute of Health for funding, and there are many other private funding sources you can apply. So the masters also train you for that, like how to get trained to write for funding,
Okay.
because funding is a very competitive process. Like not everybody who applies for funding gets funded for the research they want to do. But you can do some research which doesn't need any money. You can always do that. But
Mhm.
I'm talking about some of the research you want to do, which may require resources like the equipment, how to buy that, etc.
Right. Okay. Thank you for that. So, now let's shift gears and talk a little bit more about neonatology. So, can you describe your daily routine as a neonatologist? What does a typical day look like?
Okay, so I'm gonna divide into two categories. One is, let's say I'm an academic neonatologist and I am on a clinical service.
Okay.
Okay, so then basically you are on a service in the neonatal ICU. So you go in around like eight. We reach around like 8 a.m. in the morning. We do round on the patients. We finish rounding by 11 or 10, 12. Then you kind of talk to the families, whose babies are in the NICU. You write your notes, you talk to the team, and you most of the time you get done everything by like 3 or 4 p.m.
Mhm.
So that's a typical day if I am on clinical service. Let's say I'm not on clinical service. As I said, in academic setting, you may be doing research half of the year. So
Mhm.
in that case, I will go in my office. Usually most people will have an office space. So you go there, you kind of overlook all the projects you've been trying to do, the research. Some people do quality improvement projects. So there is a difference between quality improvement and research. That's a totally separate talk, which we don't need to delve into that. Yeah, so either you're doing quality improvement or research, or you can use your office space to do that. So you can get done sooner. You have a little bit more flexibility when you want to walk into the office and when you want to leave, because you don't have clinical responsibility during that day. But that's an academic setting. Okay. Now, going to a private practice, most of the private practice models, they sometimes work like 1 week on or 1 week off. So
Okay.
I might be on service for 1 week. That means I go in the morning round and then come back, but I will still be on call. They
Mhm.
can call me for questions during that week.
Mhm.
And when I'm off, I'm off. Some places in private practice will have 2 weeks on, 2 weeks off. So that is the private practice typical model.
Mhm.
On the other hand, most of the neonatologists, they also do overnight calls, especially if it's not a private practice model. Like an academic model, I will also be doing like 2 or 3 calls in a month,
Mhm.
or even more, depending on the place you practice. In that case, I could be either in-house, depending on the place, depending on, because there's so much variability how people practice. But I could be uh, in my house and backup call, or I might be in-house, staying inside the hospital, depending on the hospital type or location. So this is how the typical day works.
Mhm. Okay. Thank you so much for that. So, the next question is, what are some pros and cons of becoming a neonatologist?
Okay, so I'm going to talk about pros. Most of the pros I already talked about in terms of the characteristics of specialty. Like, you kind of, the main pro is, for example, as I said, like, it's the only part of the hospital where people come for celebration. So that gives you, it feels like rewarding. And the biggest rewarding part of neonatology is like you took care of a baby at birth. The
Mhm.
baby was sick. You are part of the team which resuscitated the baby, and that baby lives 90 years.
Mhm.
Okay, so you have like high impact intervention.
Mhm.
Uh, it's not just you. There is a team, the nursing staff, respiratory therapist, everybody. So you kind of get invested in something. Hey, this baby who was so sick, and our team did a wonderful resuscitation, and now look, he is going home, and the same baby will come after years, like grown up, and will know you. So that's like a fascinating part of this specialty, is right. The cons is like, the biggest cons is like, it's intensive care.
Mhm.
You are on call. It's work life balance can be an issue, because especially if you're working like, aggressively in clinical setting, and even in private practice, or even in academic setting. I think depending on where you work, you might have a very hectic, busy job. Okay, so that is the cons. The other is the pediatric specialty or subspecialty, neonatology. You can not be compensated the amount of work you might be doing. So those are the cons. And the pros, I mentioned that at the end of the day, people are usually happier. I haven't seen many people complaining as a specialty.
Mhm.
They complain a lot of other things, but they they don't usually complain, oh, I should have done differently. Most people will say, if given a second chance, I will do the same thing again, which
Yeah.
actually tells you a lot about a specialty.
Yeah.
That, okay, these people like it, so that means there is something good. So in summary, the good aspects are actually the characteristics of neonatology as a specialty,
Mhm.
and the cons are basically being intensive care and being a pediatric subspecialty.
Um, Thank you for that. So there is a different subspecialty or fellowship called pediatric hospitalist, right?
Yeah.
So that is different from neonatology, right?
Yes. So neonatology basically is, you do a fellowship in neonatal perinatal medicine.
Okay.
It's a 3 year fellowship.
Mhm.
You Most of the times you work in the neonatal ICU. And I think that was the main reason we having this meeting, is like in what kind of admissions you get. And when you delve into that, I will explain to you.
Yeah,
And I don't know how much time you guys have. We already
it's
almost
not an
like
issue for us. We can keep
okay.
going.
Okay. Yeah. So hospitalist program is relatively newer. So
Mm.
this is more for general peds,
Okay.
like, general pediatric. For example, um, many so the kind of practice the hospitalist does is they usually take care of the inpatients admitted for general peds.
Mhm.
Neonatology separates from it, that because neonatology, most of the babies after birth, they enter into the ICU.
Mhm.
Once they go home,
Mhm.
if they get sick, they come to the pediatric floor. the
Okay.
general pediatric floor. Like, many NICUs have different kind of criteria when they want to readmit into the NICU. For example, in our NICUs, where I have practiced so far, if a baby is discharged home and stays in home a couple of days, they will not readmit back into the NICU. And the main concern is they don't want the baby to bring back infections
Mhm.
because they have other premature babies in the NICU. So those babies, they will go into the general peds floor. And general peds also has many other grown-up kids to be admitted, like, and they are not sick enough that they should go to ICU, but they need to be in the hospital. And the common example is dehydration, for example, or they need IV fluids, but they don't need to be in the ICU. Uh, and if they need ICU, for example, a 2-year-old, 3-year-old needs ICU, they go to pediatric ICU or PICU,
Mhm.
not neonatal ICU. In neonatal ICU, the admissions we get most of the time right after birth. And I think this is the main talk, and I can streamline what kind of admissions we usually get.
All right. Since we're on that topic, you can go ahead and tell us about that.
Yeah. So basically, there are first you have to understand what NICU is and what kind of NICUs we usually practice in. So first thing is there are 4 levels of NICU care, like level 1, 2, 3, 4. The level 1 is like the simple well baby nursery. Uh, there's also called postpartum unit, where the mother will be in the room with the baby. We call it mother infant room. And that postpartum area will also have a newborn nursery, you know. For example, if a baby needs a little bit of observation, we will bring to the nursery, put on the monitors, pulse ox, etc. Or if the baby needs a little bit of like some procedure, like for example, circumcisions, you bring to the nursery, you do the procedure, and you take the baby back to the mom.
Mhm.
So most of the babies in level 1, they stay in the mother's room with the mother.
Right.
But if they need a little bit of brief intervention or observation, they can be brought to level 1 nursery room
Mhm.
where we can do, and then that's a level 1. Okay. So that basically many places the pediatricians take care of those level 1 nurseries. You don't need a neonatologist to do that.
Mhm.
Okay. Now going to the NICU, which is the level 2 or onward. So level 2, some places call it special care nursery. So there is a criteria you have to be in level 2. Like if the baby is less than 35 weeks or more than 32 weeks. Okay. So those babies, they usually can stay in level 2. And if they don't have any other complex issue which can make them transfer to a higher level. And level 3 is basically you are less than 32 weeks, or if you have a problem which is more complex, which cannot be handled at level 2. So, but the level 3, they don't usually do even higher level of tertiary care like ECMO or extracorporeal membrane oxygenation or hypothermia, therapeutic hypothermia, or surgical subspecialties or other subspecialties. If you need, then you need level 4. So basically, the higher the level, the more tertiary care hospital you're moving to. And then the level 4 is the one where you can get everything done, like, including ECMO, all the subspecialties, therapeutic hypothermia, and those kind of treatment you can get. So that is the structure, how the NICUs work. Now, the main question is what kind of admissions you get, and where you. So the most common admission we actually get as a neonatologist is prematurity.
Mhm.
Okay. So any baby who is born less than 35 weeks, we usually admit in the NICU. Okay. Any baby who's less than 35 weeks. They, depending on how premature they are, they can go to level 2 if it's 34 week or good size baby, or 33 week or level 2, or If it's like a 23 weeker or 24 weeker, in US we see them like a lot, and they will go to either level 3 or level 4. Okay. So special care nursery is usually between 32 and 35. So prematurity is the number one. And if I have to give a number, almost 50 to 60% of our admissions are prematurity. The
Mhm.
main reason is prematurity. Okay. The second most common, and then I think the next nine things I'm going to tell you, they are either like 1 to 10% range. They are, and the second one is respiratory problems. Now, it can overlap. You might be premature and also have respiratory problems. So you have to be in the NICU. But you can also have just a respiratory problem. You're not premature.
Mhm.
You are a big term baby. You're born at 9 months and you have just respiratory distress. And the most common reasons are like respiratory distress syndrome, especially if they are premature. They don't have enough surfactant and they need a little bit of sport, so they can be in the NICU for that reason. Or if you are a big term baby, you may have like something we call transient tachypnea of newborn, where you have like a delayed transition and you may have some fluid in the lungs, which needs more time to clear out.
Mhm.
And you can have meconium aspiration syndrome, where baby had past meconium before birth, and the amniotic fluid had meconium, and baby aspirated, and they can, have respiratory distress because of that.
Mhm.
Then pneumonia is another thing to consider, like if they have like a maternal infection causing like aspiration into the lungs, and then uh, you know they can have pneumonia at birth. Okay.
Right.
Then the other things you can have is growth restriction. Like, it's also pretty common. We see that the growth restriction, for example, if a baby is term like 40 weeks, but he weighs very small, we don't keep them in with the mother. We can bring them into the NICU, especially if they are less than 2 kilos.
Mhm.
Or some NICUs allow between 2 kilo and 2.5 kilo babies to stay in with mother, depending on how the baby is doing. We monitor them still, like for sugars, blood sugar being normal, they can stay with mom. The other thing we see commonly in NICU admissions is hyperbilirubinemia. So hyperbilirubinemia can be managed with the mother. We can use a Billy blanket and the light. You probably, I'm not sure if you heard that. The Billy blanket is a blue light which helps to treat the indirect hyperbilirubinemia. But if it's due to some reason which is more dangerous, like the baby is having hemolysis, then we move them to the NICU.
Okay.
We admit them in the NICU. Then infection could be another reason for admission to the NICU. For example, I touched about pneumonia, but it could be sepsis, general sepsis like meningitis. So it could be bacteremia, meningitis. And I don't want to delve into it, but there is a early onset sepsis, late onset, but that you don't have to as a medical student. But we see a lot of early onset sepsis, especially there are three common organisms in newborns we worry about: group B strep, the
Mhm.
GBS,
Yeah.
um, E. coli, and
Listeria.
uh,
Is it listeria or no?
Listeria. Yeah, yeah. I thought you said, yeah, Listeria. So we give them ampicillin and gentamicin as empiric antibiotics. Yeah, so those are pretty common admissions. Like, you see them all the time. The baby looked like it had some concerns about sepsis. They will admit into the NICU. And then congenital anomalies. Like, for example, we have recently, I had a baby who had a hypoplastic left heart. So that baby has to go to NICU.
Mhm.
Um, any other congenital anomalies, like they can have hydrocephalus. There's so many. I mean, the list is pretty long.
Mhm.
But if they have a congenital anomaly which needs more monitoring, attention, or intervention, should go to the NICU. Then some of the things which you can encounter is like surgical issues. For example, I had a baby just recently who had imperforate anus, so they need to do like some intervention. So they need to go to NICU. And you can also have baby who have birth asphyxia, like the baby was fine, there was no problem, but after, at birth had sometimes can have cord around the neck,
Right.
which can compress the cord.
Mhm.
And uh, those babies we call we worry about encephalopathy or hypoxic ischemic
Right.
encephalopathy. And that, and if they have moderate to severe encephalopathy, the treatment which works for them is called therapeutic hypothermia. They need to be cooled.
Mm.
And I think I used that term before.
Yes, you did.
Yeah. So yeah, so those babies, they need cooling. Their temperature needs to be dropped. So we have cooling blankets, the cooling hat we put on, especially if they qualify. They don't qualify if they're premature, like especially if they're less than 34 weeks. But if they're big term baby, they just had an event at birth. During the birthing process, we admit them for evaluation for therapeutic hypothermia, and usually the level 3 or onward NICUs they do it.
Can you describe how the therapeutic hypothermia works for the baby?
Well, so basically, the popular theory is that so you want to cool down the whole inflammatory response.
Okay.
Okay, so you want to cool it down.
Mhm.
There's a big famous trial, Toby trial, which actually this is one of the things which we have evidence, very strong evidence. It's one of the area where litigation happens if you don't start therapeutic hypothermia on time, because it makes a difference.
Mhm.
So it has to be started within 6 hours after birth
Okay.
to make a difference, because that's what the evidence suggests. So you drop the baby's temperature to like 33.5 centigrade.
Mhm.
Normally it should be around like 37 around, right? So you drop it and you keep it for like 3 days,
Mm.
like that. And then those babies over the years, they have shown they do better neurologically, and they do better.
Mhm.
Unfortunately, it's very difficult and challenging to do in third world countries. You need to have a lot of training, you need a staff, special equipment, device, all those things. But that's something which makes a difference. Okay.
So there are a lot of patients that come up and like we're in our pediatric wards and we find out that there are a lot of cerebral palsy patients. And usually the cause was birth asphyxia during the delivery. So is cerebral palsy due to birth asphyxia something you see in the United States?
It can happen depending on how bad the birth asphyxia was or how bad the encephalopathy was.
Mhm.
But most of the cerebral palsy we see is because of prematurity here. Because remember that cerebral palsy is like abnormal motor system, basically, most of the time. It can also affect the cognitive part and other aspects, speech and fine motor skills.
Mhm.
But do you guys remember the homunculus picture?
Yes.
You remember?
Yeah.
Did you see how the legs drop in the middle
Yes.
in the homunculus?
Mhm.
So that's where the ventricles are. So premature babies, they have something we call intraventricular hemorrhage.
Right.
So once that hemorrhage happens, it stretches on the area which is right next to the ventricles. So that's
Mhm.
where the legs are.
Okay.
So that's where the legs are. So once they have big grade 4 intraventricular hemorrhage, they have a risk of having cerebral palsy because their legs will become rigid.
Mhm.
uh, so prematurity is the more common cause of cerebral palsy. Birth asphyxia can also do that. uh, but birth asphyxia will have more like of a global impact versus more versus specific to the motor aspect.
Mhm.
uh, but but yeah, I mean, we do see, I don't usually practice as an outpatient for a while now, but when I was being trained and I used to do clinic, we used to see babies with cerebral palsy because of the reasons you mentioned. Birth asphyxia and prematurity was actually more common in my experience.
Thank you for that. Okay, so our next question is basically, what advice would you like to give Pakistani medical students that are starting their journey towards becoming a pediatrician in the United States? What are some things that we can do right now? Any specific advice for us?
Um, my main advice would be um, at this stage, you have to be on top of your game in terms of knowledge and skills. I think this is the learning phase you're going through. Okay. Uh, the better you build on yourself on those kind of stages, it will have impact how you're going to perform later on.
Mhm.
The other thing I would say is the motivation. If pediatrics is what motivates you, you have to show consistency on what you want to do.
Right.
You have to show genuine interest in it, um, and plan as much as you can. Get exposure to as many things you can in pediatrics.
Mhm.
Dig deep into the specialty, know like small details how the specialty works, how, as you guys have rightly asked me all those questions, like, but dig yourself as well, like, how the life will be, is this what I want? uh, but I think from Pakistan's perspective, if you want to practice in Pakistan needs more pediatrician than US. I feel the reason being is because our neonatal mortality is pretty high.
Mhm.
Our maternal mortality is pretty high. We have been working on it as a nation for a while to actually improve, and it's embarrassing, like, how our numbers are. Um, Pakistan is in many ways, there is a lot of scope for pediatricians if they choose as a specialty to actually rise up the ladder, because uh, there there's a like huge gap where the things should be and where the things can be, like, right now where they are and where they can be. And if you guys have motivation, I think that will make you happier because you can make a difference if you actually adopt this as a profession and you are genuinely interested in it. It will make you even more happier because you will be making a difference on a problem which is in front of you. Because sometimes the things, they don't excite us because we feel like there is not a problem, I'm just one of the many things in there. But here you have a problem. We need better care for newborns, we need better care for maternal health. So if you choose this as a specialty, you will not be devoid of ideas what to do in life. That
Mhm.
is the what I'm trying to say. So at this stage, just learn more about it and see how the specialty will look like. I think it's amazing specialty to choose the pediatrics. And more people, like, for example, you're doing a wonderful job, you have this interest group, which is actually very new idea. I think this also will expose more people to the specialty. As I said, like, in our culture in Pakistan, people are driven by peer pressures. They
Mhm.
don't really make choices by looking themselves, what things happen in particular area. A lot
Mhm.
of people will say, oh, I want to be heart surgeon, I want to be neurosurgeon, I want to be, because this is what they hear.
Right.
This is how we depict things. uh, but if you decide independently, you will see that this is an amazing area to be in. So my advice will be that polish your skills, stay ahead of the game because the world is changing very quickly. And I'm telling you, when I was in medical school, the emails just have I just made my first email when I was a second year medical student. And now we have artificial intelligence, which is going to change the whole landscape drastically in next 5 years.
Mhm.
And the interesting part is the change is accelerating.
Mhm.
Change is not slowing down and it's not stagnant, it's accelerating. So if you want to compete in your field, you have to be on top of your game. And the main top of the game is like you need to learn skills. You need to learn skills which are useful at hand or at the ground or where you are, which could be like even online skills, like how to use systems and how to basically adapt quickly to the changing world. I think that is where your area is, your focus should be. I think one problem we having in medical schools in Pakistan is that uh, we are behind in terms of curriculum, the kind of the skills we need. For example, when I started medical school, there were very few places had electronic records at that time. Actually, no, it's like you can't even think about working without them. Okay, so see how things are changing. You have to learn new skills and always try to keep learning new skills because things are changing, and adjust yourself in a way that you're happier with them.
Mhm.
Yeah, that's the key. So my uh, bottom line is that you have to learn new skills in a
So,
changing world.
so you mentioned learning new skills. What are some, for example, online courses or something that we can achieve where we are right now that can help us in the future?
The main is
Okay.
the research skills. For example, how many of you know that what is R programming, for example? Have you heard this name? Yeah. So I will give you a few things. For example, how to do statistical analysis.
Mhm.
For example, if you know this, if you are really good at statistical analysis, you will be the most wanted person because they will be looking out for you. Because so those are the areas. Learn how to conduct like a good quality research.
Mhm.
Learn how to write research paper. Learn how to write grant, like a funding. Those kind of things. So
Mhm.
those kind of skills I'm talking. Those are just are examples basically. So anything which will excel you in academia is what at this stage you should learn. You may end up not doing an academia, but learning those skills will be important because that's how you're going to make a choice that, okay, I learned everything and I feel like I don't want to do it.
Mhm.
Okay. But if you learn everything and you feel like you want to do it, you basically hit at the right place.
Right.
Yeah, so research skill is what I'm trying to emphasize at this, because remember that you can be ahead of game because you might be good at publishing stuff, and go at nitty-gritty details, how to write a research paper, how to get funded, what kind of grant mechanisms are available, those kind of things. If you're thinking to come to US, I'm talking. Even in Pakistan, I think if you know those skills, you will be ahead of everybody. You will be the one people will look after. Hey, I want to do research. You have experience, so can you help us? So I think those are the newer skills where we should move our curriculum and our medical school curriculum. Uh, that should be the direction I feel.
Do you happen to know how we can obtain these skills? Like, for example, the grant writing or statistical analysis. What is one way that we can learn these skills?
So um, so I think I would you have the we don't have biostatistics as a
We do,
uh, we do have.
yeah.
Yeah.
It's not,
So
but we do have it.
yeah, so I think I'm not saying you should learn at the PhD level or you should learn at, but first step is to learn what kind of things they have. For example, I think the first thing you can do is, um, if you are interested in research, for example, I just give you the name. For example, learn how the R work, how Python work, how
Mhm.
the coding works. Those are the new skills of the future. Most of the innovations happening where the two different areas they meet.
Mhm.
Someone who knows medical field and biomedical engineering, for example, will do wonders
Mhm.
versus if you are just in biomedical engineer or a medical specialist. So where areas bridge, those skills you should learn. The clinician should not be just learning about because medicine now is overlapping across different fields, even media. For example, if you know video editing, as an example, you can actually create video content which is health related.
Mhm.
So all these skills they matter in the end. In the coming, my prediction is the next 5 years is an era which will be uh, way different than where we are. And so I'm just giving a broader perspective. I'm not giving you specifics. I
Mhm.
think it will. There are a lot of specifics about every area. For example, the applications of new artificial intelligence, like we don't really know how it's going to outplay, like how it will lay out the landscape.
Mhm.
So all these are skills basically you need to know. You should be on top of game how to use artificial intelligence in a way which helps you to progress and move forward, so you are more efficient. I think artificial intelligence you guys should just learn like on your finger toes now, because uh, fingertips now, because yeah, I will tell you, for example, there are things you can do, for example, with artificial intelligence, which we never imagined we could do, like the automation part. Like,
Mhm.
for example, the Zapier and the Make. I'm just throwing these names because if you search them, this is probably your task. Just look for what is R programming, what is uh, Zapier, Make, kind of automation. You can do amazing things. You can even, like, we used to manually enter data in spreadsheets.
Mhm.
You can actually use artificial intelligence to do things which you would have taken like months to do.
Mhm.
These are the skills I'm talking about,
Okay.
to be ahead of the game. And you can if you are really good at them, you can even put in your CV, I know how to use it.
Like, for example, we can obtain certificates from
You
different
can,
universities and
yeah, there are many online resources. Even Harvard offers many online free kind of courses.
Mhm.
So once you complete it, put it in your CV. Basically, that's how you enhance your skill. And I want you to be genuinely be skilled, not just on the paper.
Right.
Because if you are genuinely skilled, you will be amazed how many things you can do in life.
Mhm.
It's just because you don't know. I think that is the that is the problem. And I'm giving more general kind of uh, layout versus telling you specifics, because everybody has different interests. So
Right.
if I say, okay, just do statistics, someone will say I don't like it, so that's fine. So but I'm just throwing you as an example, like there are so many new skills you can learn, and you can think about how you can add to your CV.
Right.
Yeah.
Okay. Um, and so basically, we as medical students feel like, especially as IMGs, that obtaining electives in general in the United States is pretty difficult, let alone just in pediatrics. So, what is some advice that you can give us about obtaining electives?
I think uh, we are behind because there is a like a website called Also. Is that
What is it
the
called?
is that I forgot the name. There is a platform where you apply for electives,
VSLO?
and VSLO,
Yeah.
yes, yeah, VSLO. I think it's harder to get electives through VSLO, right? That is what the question is. Yeah. But I think electives people can do. You can talk directly to the pediatrician. I think electives are you can get easily from out of VSLO. That is what I'm trying to
Mhm.
say. You just have to find someone, especially if they're doing a private practice.
Mhm.
In academic settings, it's harder. I will tell you why. The hospitals, they lay out their rules and regulations, and there is a HIPAA, restraint, like you don't want to share medical information with someone. So you have to get ID badge and everything. Where I work, for example, I work in three different health systems, and they all require some sort of process to pass through, and then you can have. But if someone has a private practice and they run their own practice, they can accept medical students, and then they just have to write a letter what you did during the rotation, and I think that should be fine. It's not as difficult because you have to see the logistics of it, because you might find someone, but they might be in a place where you don't know anyone, and it might be expensive. So there are logistic issues. I don't think so they're difficult to find. I think everybody's scenario does not fit there.
Okay, perfect.
Yeah.
Thank you so much for that. So, we had a question about how people go directly for fellowship instead of residency in the United States. So, what is your stance on that?
So it used to be more popular in specialities where they were having hard time finding fellows.
Mhm.
Uh, and lately, it actually neonatology was one of them at one point, and even now, I think there are many programs they did not get filled. So residency is harder to find. In those cases, the fellowship is easier. Now, if you have passed your USMLE exams and you have done step 1, 2, 3, and you have some experience in that specialty in Pakistan, I think that will work best for that person. Now, the advantage of having this fellowship is that you get the fellowship, then most of the times the same program will accept you for residency
Right.
because they know it. They know that you worked there for 3 years. You probably know system better,
Mhm.
and if they like you, they will not even let you go anywhere, because they will request you, please stay with us because you have experience and we like you. So this is another way of entering into residency. At the end of the day, your goal is to get residency done, because even if you end up doing fellowship, you will not be able to practice independently.
Right.
Some places may give you license because there are some changes in the rules, but most of the states, they will not license you until you have finished the full residency. So you do basically fellowship first and then residency.
Mhm.
I know a lot of people have done it. I know a lot of friends who did it, and if you have an opportunity like that, I would take it.
Okay.
Uh, yeah.
All right. So, I don't think it's possible for someone to apply to both residency and fellowship, right? In one cycle?
Yes, it will feel odd. It is, I mean, it is possible.
Okay.
I'm not sure how the timing will work, but it's possible, especially if you have experience of working in pediatrics, for example. You have worked a couple of years in peds, and now you did not match, or you have low hopes of getting matched, then if you are offered a direct fellowship, you should take it. But it's possible if you apply, but my suggestion would be that should not be your primary focus, because it comes with drawbacks. The main drawback is that once you're done with fellowship, you go back to residency, and basically many of your interns who you were a fellow, they were interns, now they become fellows and you are their intern.
Okay.
So it's okay. I don't think so it has any major issue with it, but I feel that if you can get residency first, that will be the ideal scenario. And then most of the fellowship places, they also offer J1.
Mhm.
uh, and then you have to be on J1 in residency, and then you have to find a waiver job because J1 has its own problems versus H1. My suggestion would be finish your steps with the high scores, including step 3, get a couple of publications, get US clinical experience, and then you're ready to get into residency. And if you don't need visa, you have 100% chance of getting into residency.
Okay.
Yeah.
Okay.
especially if you have good scores and good experience.
So you were talking about good scores. We have heard that in pediatrics, a good score is not the same as an IM. Some people have said that scores that are low in IM would still qualify as good scores for pediatrics. So do you think that's true?
I think the good score is a good score. It doesn't matter which specialty you are. Um, if you are competing with someone who has like less score than you will have an advantage,
Mhm.
even in peds.
Okay.
Now, now that is one aspect of it. But then if the other person has done clinical experience way better than you, they might consider him more or her more.
Mhm.
So there, but it's, I think in general it should matter.
Okay.
Yeah.
And then for step three, some people have said that step three is a hidden requirement for IMGs to match into residency. Do you think that's true?
It's not true because, as I said, I matched without step three.
Mhm.
Um, and a lot of people match without step three, especially if they're fresh graduate,
Mhm.
because they don't expect you to have step three. But if you have step three, a lot of programs, especially IMG friendly, some of their trainees, they have trouble passing step three. So when they look back into the applicants, they see, hey, we have someone who already passed step three. We will not have to worry about him. Because if you fail step three during training, the program will look negative on you.
Mhm.
And they, if you have already passed, it will put you ahead of some of the applicants who have not passed step three.
Mhm. Okay.
Yeah, so having it obviously better than not having it,
Right.
but it's not absolute requirement. As I am one example in front of you because I did during my training.
All right. Thank you for that. And congratulations on being the president-elect for APPNA Peds. Would you like to describe a little bit about APPNA Peds to our viewers?
Sure, yeah. So APPNA Pediatrics is a specialty chapter of Central APPNA. You know, you guys are familiar with APPNA.
Yes.
It's a Pakistani doctors organizations of North America, basically. And uh, APPNA is, I would say, APPNA is very valuable organization. If I have to pick one organization out of Pakistan which has actually more influence than any other, then I would say APPNA in terms of they do a lot of things. And we, as APPNA Pediatrics, are a relatively newer chapter. We were established in 2015. So we are kind of going through a phase of establishing itself, establishing its infrastructure, basically. You know, we're trying to find which direction we should move. Because one perception of APNA is it's all like social gatherings, right? So we want to make sure that we don't just have that perception. We also want to make it more like, you know, to facilitate uh, people from Pakistan who come here to get into residency with more competitive application, to excel in their training and to excel after training, and also lay out all the information, because at the end of the information is like, you know, kind of a power. If you have a lot of information that helps people be on top of their game, so we want to align UpNaPeds more into that direction. At the same time, we also want to value what we do for other things, like to connect people together, to have, you know, now in US, for example, there is a third, fourth, fifth generation of Pakistani descent people are living. So now the dynamics are different. So before that, we were more focused towards Pakistan, you know, we still are because, for example, infant mortality, neonatal mortality, and maternal mortality is one of the areas of our interest. But at the same time, we also want to focus when we are here how we can be more competitive, how we can actually improve our skills in a way that we can face all the challenges here. So that is the role where we are trying to direct APPNA Peds. I did work for like a couple of years as a secretary, and now for next 2 years. So we have like a 2 year cycle.
Mhm.
So 25, 26 is the cycle where I have been honored with this position. So, but we are trying to lay out for future, like, how we can be more helpful for people.
Perfect. Thank you so much for your time, Dr. Khan. We would like to open the next session as Q&A for whoever has some questions. I believe, Kunut, you have a question? Go ahead. Kunut is our honorary secretary at SIGB.
Okay.
Assalamualaikum, sir.
Walaikum salam.
Okay, Dr. Khan. So I am Punita Khan. I'm a postgraduate medical student at Dow Medical College and honorary secretary at SIGB. First of all, very delightful to have you here. Thank you so much for giving us time. Sir, I had a couple of questions. Number one being that you mentioned that you did your FCPS in surgery, right?
I
So,
just did the part one.
oh, okay,
Yeah, I
okay.
didn't do the training. Yeah, I just did the part one FCPS exam, basically.
Okay. So,
Yeah.
but you were interested in surgery as well, right? So, why didn't you choose pediatric surgery instead of just pediatrics? Like you had
Yeah.
interest.
Yes, that is a good question. Remember that pediatric surgery is a very competitive specialty in US to get into. Um, and I have to admit that I felt that it's kind of uphill task for me to get into surgery here in US because I needed a lot more time commitment and need to improve my CV to the level that I could enter into surgical program. Besides, the lifestyle of surgery requires a lot of commitment, which I felt like considering my personal circumstances, I felt like it wasn't feasible for me to go for it. Um, so as I mentioned, when I did 2 months in pediatric oncology, I had made my mind at that time, even in Pakistan, that I will not do surgery, uh, even in Pakistan at that time. Yeah. So going back to your question, I think it's very challenging to get into residency here. It's a long training program, and then you have to do subspecialty, subspecialized, like in pediatric surgery. I think it's a long process, and the lifestyle is very demanding and challenging.
Okay, thanks so much, sir. Also, sir, Dr. Khan, I was going through your researches. So I must say those are very interesting. Um, I noticed that there were several researches on N-terminal pro-beta hydrogenatic peptide and its correlation with the prematurity and bronchopulmonary dysplasia. And then there were more research. There was another research on thyroid scans and prematurity. So I found them very interesting. Can you tell something about those? What was your motivation behind it, and how did you proceed with it?
Sure. Yeah. Yeah. Thank you for bringing that up. Yeah. So I did NT-proBNP is a marker which is usually released from the cardiac myocytes when there is a volume or pressure overload into the myocardium. So as part of my fellowship project, uh, during fellowship, you have to do a research project. So this was part of that requirement that I became interested in NT-proBNP, and I was more interested in urinary NT-proBNP because remember, in premature babies, drawing blood is difficult. You want to save blood because if you draw too much blood, you have to transfuse the baby, right? So my excitement was we can use urine and we can test urine for NT-proBNP and see if the NT-proBNP is elevated in reference to the patent ductus arteriosus, which usually can cause pressure or volume overload in a premature infant. So the idea was to see if there's a correlation between NT-proBNP and the size of ductus arteriosus. And we found like there is a direct correlation. The higher the NT-proBNP, the high likelihood that the baby may have a bigger ductus. Then we followed up those babies also if they develop bronchopulmonary dysplasia, because when they develop bronchopulmonary dysplasia later on, they develop pulmonary hypertension. And that also causes pressure load on the ventricles. And then we noticed that there is a late rise to the NT-proBNP. So we were trying to see if it has a feasibility to be used as a clinical marker for pulmonary hypertension. And the urine was my main focus because I feel like you can collect urine anytime and it's non-invasive and those kind of excitements I had. So regarding thyroid study, which was done, one of my senior colleagues and I actually picked up this project once she actually moved to a different place. So in this study, what we did was we measured the thyroid gland size in the premature babies, and we wanted to see how they grow and if the growth has any relationship with any other factors. It was an interesting study, I agree, and not it was not easy to do, and I have to give more credit to my colleague who actually started this project, and I actually ended up publishing it, and uh, because she had done all the hard work, and I actually did analyze the data and wrote the manuscript for it, and it got published in a good journal.
It was very interesting. I'm someone who is really fond of research. So like finding those studies were like a true blessing because it was like so interesting. Thank you so much.
Oh, well, you're welcome.
So just on that note about research, is there any way that international medical students like ourselves can collaborate with pediatricians in the US in regards to research?
Yes, I think the main point is that I think as a starter, if someone is doing research, like, you can join them, as part of their team. Um, I think nowadays you probably will have some opportunities where you can stay back in Pakistan and still contribute to the research, because there are a lot of online research you can do, especially the data gathering. And as I said, if you have the skills of statistical analysis, that will be even way better and handy for someone. The other thing could be to join someone who has a lab. If you are physically here, then you can find someone who has their own lab, especially the basic science lab, and you can also think about that. But I think you have to explore those opportunities. Depends on, like, for example, I was way more active in research when I was in academic job. Now my dynamics have changed, and I'm more focused on now this kind of APPNA Peds role and the health education. We also make YouTube videos for maternity health. So I'm more focused on that. So I'm not doing the kind of research which will benefit you, but I think this is worth exploring. And I think the best thing will be if you find someone who is an academic job, and the way you know it, if they have designation as an assistant or associate professor with them, that means they are in an academic job. And even in Pakistan, if you see an interesting case, for example, you are a medical student, you go into the ward and you see a newborn which has very unique genetic presentation, and you have all the information, you can write a case report and you can present to the attending there. And nowadays, finding information how to write a case report and how to write a paper is not difficult. You have all the resources now. So you can say, Dr. XYZ, I am interested in writing up this case, for example. So, and I have written a draft. Can you review with me? it's better to do that with someone who has published. Because
Mhm.
if you do someone who hasn't published, you will not get anywhere, because the experience matters.
Mhm.
Um, but if you need, like, if you want me to review something quickly, I'm happy to help you guys. If you come up with some idea you want to do in Pakistan, and that can also come to your CV, for example, like if you see an interesting case, or if you want to see something, even case series you can do, like the case series. So there are different types of research you can, like randomized controlled trial or double blind, and these are the ultimate big kind of things which you usually do when you're an attending level. But as a medical student or resident, you can do things which are simple, like a case report, or join a team which is doing randomized controlled trial. For example, when I was resident, I joined the trial budesonide and surfactant, which was pretty handy for me to learn how to do research.
Mhm.
So you have to take first step, and the first step could be to learn how to write a manuscript. Uh, like if you can start with the case report. The neo reviews. There is a pediatric reviews. You can find journals, and you will see they will have case reports in it, and you can see how they are writing it.
Mhm.
You can get the idea how they're writing the case report. And if you go in the ward and you see an interesting case, you should talk to your attending. They will actually appreciate you if you do that
Yeah.
you're interested in research. I think motivation matters a lot. And if at your age, you guys have motivation, I think you guys can do this. It's not as difficult as you feel.
Mhm. All right. Thank you so much for that. Does anyone else have any other questions? Dr. Khan, you mentioned that you guys have a YouTube channel where you talk about maternal health. Um, yeah, go
Yeah.
ahead.
So I so so I am actually also chairing innovative health education committee in under APPNA Peds. That was the main driving factor I actually got involved in APPNA Peds. So we want to make APPNA Pediatrics main channel to be more active. Okay. So we're planning to interview obstetricians in Pakistan in local languages with the public interest questions.
Okay.
Uh, so in their local languages, like in Punjabi, Sindhi,
Mhm.
Pashto, even in Urdu. So we will have those. That channel is still dormant, but on the sideline, I am experimenting to improve my skills. So when I come to the main platform, I have those. So I have a channel. I can share you the link.
Mhm.
Um, like for example, right now I'm writing like first month of pregnancy, the Hamal ka pehla Meena, like those, and then I wrote like I have written script for like first 9 months.
Mhm.
So I just before this lecture, I just finished the fourth month video, but I haven't uploaded. I can send you the link, but that is just experimental videos.
Okay.
But we want to build on it. And our plan is any activity which we will do, for example, research training. We have a research training committee as well. We have streamlined all. If you look at the document I shared, I'm not sure if you guys can see that. I can share with you the document of APPNA Pediatrics, the structure, how it works.
Sure.
Like it has like different committees.
Mhm.
There's a neonatology committee, pediatric ICU, and emergency committee. There is also like other committees, like so in those committees, so they will do all those activities online. We're planning to put them in the channel. Like I am the innovative health education committee, so if I'm working on these like maternity health and child health, newborn health videos, and someone will be doing videos on the research training, how to write a grant, all the questions I just talked about.
Yeah.
But in future, we will put all this information into the channel.
Okay. Perfect.
So everybody can access it.
All right.
Yeah, we are behind. And I apologize. We are behind on those things because our organization is newer
Yeah, of
relatively.
course.
We just starting to warm up.
Yeah. We'll be waiting. Inshallah, it'll come soon.
Uh,
Just one more question on my end. So you talked about interview skills, and I think that's something that most IMDs are lacking. Is there a way that we can polish these interview skills for our residency interviews?
I think practice is the key.
Mhm.
There are two aspects to this practice, actually three aspects. One is how you articulate stuff, how you articulate, how you pronounce, because there will be some words which are different what they're written, but they're spoken differently. You should know all those things. These are articulation part. Then there is a body language part of it. If I am you, I will enhance my personality skills and focus on that a lot. Personality skills is not just like knowing. I think our focus has been in Pakistan, and I am part of that system too, has been how to memorize things. World has moved way far from it. Memory is only one aspect of being smart. It's actually not even 10% now of the, like, we equate memory with intelligence, which is not true.
Mhm.
Intelligence is skills, basically. How many skills you have? Do you
Mhm.
speak 15 languages or you speak one language? So that is a skill, right?
Mhm.
Do you speak, you know how to use body gestures to communicate,
Mhm.
right? You know how things work in the world. You know what things Americans, for example, you interview. Do you know how Americans talk about things? Do they talk about how they talk about sports, how they talk about weather?
Mhm.
So the more you know it, the better your interview skills will become. You
Okay.
know what I mean? So skills, personality skill, and then you should practice them, like the small talk.
Mhm.
Uh, and when you practice them, don't try to be a different person what you are.
Okay.
Like, try to be the person you are, but with the newer skills.
Okay.
Like, for example, you don't have to be a different personality, or I want to be someone. Like, you can be yourself, but you have skills.
All right.
Yeah, that is what you need to focus on to improve interview skills. Need to know how to smile, when to pause, how to give, like, word choices,
Mhm.
how to be like, not speak words which may be offensive. So these things you have to know, and these are basically the skills.
All right.
Yeah,
Perfect.
practice is the key in the end, I would say.
Perfect. Thank you so much for that, Dr. Khan. If there are no more questions, that is the end of our session. I'll just wait 1 or 2 minutes. Do you have any feedback for us, Dr. Khan, about how we had this session or anything else?
Yeah, I think this is great, but I think you can make sure there, just ask like more like specific questions, which are like, uh, more, I would say 4 or 5 questions,
Okay,
and then have more time for question answer in the end.
sure.
Yeah, I think I think you guys doing wonderful job. I think these small steps, I always say that, sometimes you learn things you just don't realize you learned it. And that's called subconscious learning. I think what you're doing is amazing. You might not feel it, but you're doing amazing
Thank you.
job. I think this is the first step. The more you talk about things, the better you're getting on them. This is the way.
All right. Thank you so
Yeah.
much for your time, Dr. Khan. And we will be uploading this onto YouTube for anyone who didn't see the whole session. Thank you again, Dr. Khan, for your time.
No problem. Anytime. Thank you.
All right.
Was
Bye-bye.
pleasure. Thank you. Bye bye.